Good morning. So today we'll be talking about the mediastinal lymph node stasis, particularly for the lung cancer. So a little bit difference because it's not just like the book. We have to interpret it both with the clinical radiology and also correlate with the intraoperative findings. So therefore, we must know those lymph nodes identified in the CT scan preoperatively, and we must also remember how we can detect those lymph nodes during the surgery and properly level them. So why it is important, I will tell you in the next slides. So these are the obvious things. I will not be repeating this lung cancer, small cell, non-small cell type, what's the US incidence, prevalence, etc. What are the causative agents, risk factors. So if you go through the 2008-2014 data from the USA, it said that the most of the patients come into the mediastinal lymph node metastatic disease. It means about 24% stage 2 with node positivity stage 2. And 5-year-old survival is definitely lesser in those cases. So coming particularly the lymph node station leveling or mapping for the lung cancer. So there has been a standard practice of doing those lymph node station leveling them by the Naruke map. So it was done by the Japanese surgeon. He was very popular in those days when the concept of the extended lymphadenectomy was there for the lung cancer also. So Naruke map came in 1967. Thereafter, the American Thoracic Society in 1983, there were shortcomings in that kind of the map also. So thereafter the Mountain Dressler, again ATS, American Thoracic Society map came into function in 1987. And lastly, by 2009, because there are a lot of differences among the Eastern countries, particularly Japan, China, and Korea, who used to classify those lymph nodes according to the Naruke map system, whereas the Western society used the MD mountain classification. So the International Association for the Study on the Lung Cancer group, they have then uniformly made a consensus how to label those lymph node stations for the lung cancer. So this was the original mapping system for the Naruke. It's just for the historical interest. Long time ago, I was using the similar classification in our hospital also. I think for the first 10 years, our establishment of the hospital, we used to use this only the Naruke classification system. One they call the highest mediastinal lymph node, then 2, 3, 4, etc. There are certain differences. So since it is not being used these days, so we don't need to go into details. What is the Naruke system? So again, same. In 1987, this Mountain Dresser, it was also popular for quite a long time. Then lastly, in 2009, which was published in the journal Thoracic Oncology, and I'm proud to say there were two mentors, Valerie Rush. She is the author of the six also. You can see here the book here. Valerie Rush is one of the editors here. And also this Asamura, he comes from National Cancer Center, Japan. Both of them were my mentors, and they put their input for this IASLC lymph node mapping system or staging system for the lung cancer. So I'm not talking about why it is important. It's always important because uniformity should be there worldwide, how to classify them by TNM staging system. So again, this is how it looks like the nodal classification system by International Association of the Study of the Lung Cancer Group. So you can see it's very complicated, but it's okay if you go into details how we have to label those lymph nodes. But basically, to summarize for the clinical importance, there are the supraclav lymph nodes. We always, whatever is the lesion, if not a stage 4, it should be at least by virtue of supraclav lymph node positive, it should be this N3 disease. If they are the mediastinal lymph nodes, that is the N2 disease. If the higher or intrapulmonary lymph nodes, which are located inside the lungs, that should be classified as N1. If any contralateral lymph nodes related with the higher or mediastinal, that should be classified as N3 group of the lymph nodes. So there was a basic definition. How do you separate between the hilar lymph nodes and the mediastinal lymph nodes? So in textbook of thoracic surgery, it says that there is the boundary. If something is covered by the mediastinal pleura, that should be called as the mediastinal lymph node. If something is enclosed, enveloped inside the visceral pleura, it is particularly that will remain inside lung parenchyma, so that should be named as the hilar lymph node. So that is one of the surgical boundaries that we can maintain during the surgical exposure. to identify these groups. So this lymph node location have been traditionally divided into 14 stations. So station 1 to 9 represents mediastinal lymph nodes. If only ipsilateral, we call it N2. If it goes to the contralateral, then it becomes the N3. So stations 1 to 9 are the mediastinal lymph nodes. The stations 10 to 14 are those lymph nodes which are classified as hydral lymph nodes. So that could be N1, means ipsilateral. If that goes to the contralateral, that becomes again the N3 group of the lymph nodes. Supraclavian lymph nodes are always N3 group of the lymph node. Any extrapleural nodes, like which are located in the internal mammary chain, like for the breast cancer, if they are in the axilla, that are the lymph nodes, but none is known, that should be considered as stage M1 disease, metastasis stage 4 disease. So we must also remember what are the criteria for abnormal mediastinal lymph node on CT images. Because pre-operatively we have to define whether those lymph nodes are positive or not. We always are fond of talking about the axial short axis diameter more than 1 centimeter. It's not always true, but always we have to measure if we don't have the facility in our center till the EBUS becomes available. I think 2 or 3% of the people went for the PET scan. 5% of the people went for the mediastinoscopy. So staging was incorrect. So for those group of the people, we totally relied upon the CT scan finding. The one thing was that short axis measurement. So how do we measure the short axis in the CT scan? So in the CT scan, we have the, if it's not oval, the oval will have the equal diameter dimension in the both X and Y axis. If not that, if the longitudinal and the perpendicular and that will be the short axis that has to be measured, and once the diameter has taken in. And also abnormal shape, oval shape of the lymph nodes are generally metastatic, like shown in this picture. And also it has been said the CT specificity and sensitivity is quite low for the CT scan, but it has to be done. If there is a heterogeneous region, the boundaries are distinct, it's oval in shape, there is a central necrosis and loss of the central hilum that are suggestive for the malignant lymph node rather than benign lymph node. So that has to, those criteria exist also for the CT scan and also exist for the endobronchial ultrasound or endoscopic ultrasound. So these are the things, but 40% of all those ones thought to be malignant according to the CT findings are proven to represent benign disease. And our countries, particularly because of the benign disease, like tuberculosis or recurrent pneumonia or infections, that could be benign rather than malignant. So we should be very, we should coordinate always the clinical and radiological finding. Definitely, PET scan is superior to the CT scan. Its sensitivity and specificities are higher. So as shown in this picture, these are the lymph nodes in the CT scan. PET highlights is the high uptake in the PET scan. So again, I'm not going into details. So what's important is that we have to correlate with the CT findings and anatomical landmarks which we identify during the CT scan. So that comes for the nodal mapping. So I said, let's come first to the higher group of lymph nodes, because surgery, if possible, is always justified in that kind of group of the patient who have got only higher group of the lymph nodes positivity. It means level 10 to 14. We don't need to even prove it or disprove it that these lymph nodes are positive or not. So that's the typical picture. So that's this first come to, I said that 10 to 14. This according to this the main bronchus, this is the lower, the segmental and subsegmental. These nodes which are located this white circles, these are the nodes which are located inside the lung parenchyma, along with the subsegmental bronchus, that is level 14. If you look in the right side, we call it R, and if you look in the left side, it's called A. If level 13 means along the segmental bronchi, level 12 means along the lower bronchus, like upper lower, lower lower, etc. Level 11, this which were interlobar. Level 11, like here is the bifurcation into the upper lobe and the truncus media intermediate. This is the level 11 lymph node. In the left side also bifurcation between the upper and lower lobe. This is the level 11 lymph node again. Higher lymph nodes that we call level 10R and 10N, and we have to make an emphasis over there. It's quite confusing sometimes. Which is the level 10? We can easily mistaken with the level 4R lymph nodes. We may call it 4R. 4R means N2 group, 10R means N1 group. So there's huge disadvantage in misclassifying those lymph nodes. So now coming to the mediastinal group of lymph nodes, there's 1, 2, 9, it should be. So this is the one above the clavicles. So we transit, this is the, if you left innominate vein, this is the superior vena cava. So we go to the lower boundary, where the lower boundary transits the trachea. So from this thoracic inlet, that is the boundary from the clavicle to the inferior margin of the left innominate vein, that's the 2R. 4R means from here to the azygous vein, this is the insertion of the azygous vein into the superior vena cava. So that should be the level 4R lymph node. And we must also remember that for the right-sided group, the lateral boundary comes to the lateral aspect of the trachea. So this whole group will be the 2R and 4R up to the level of the carina. Instead of that, if we talk about the left-sided, 2L means, again the thoracic inlet, up to the upper margin of the aortic arch, that we can easily visualize in the CT scan. 4L means from the upper margin of the aortic arch to the lower margin of where the pulmonary truncus starts, that's level 4L. Which comes to the subcarina, this is the level 7. I'll be talking in detail regarding that each lymph nodes. So this is the, again, IASLC lymph node map of 2009, which I said level 1 means supraclav, which is located above the clavicles. So for that, we have to remember the uppermost margin, that the cricoid cartilage, not anywhere in the neck. It should be typically in the supraclav region. From cricoid cartilage below, alongside both sides of the trachea, that's the level 1, are shown depicted in this picture by the this brinjal color notes. So let's go the CT scan. This is the picture, anatomical picture, that we can visualize the 3D construction of the CT scan. With the sagittal image, where this is the first rib, we draw the image, we draw the line along the first rib. Whatever lies above that, that comes to the neck parts, definitely that has to be classified as level 1. Whatever lies beneath that is called mediastinal lymph. So in this way, we can classify that. Similarly, if we reconstruct them, or we take the axial view through the first rib, these are the first rib, draw horizontal line. Whatever lies above that, they change together with the 1R or 1L, that is the supraclavicular, and beneath that will be only the 2R and 2L. Again, the same, the CT scan will visualize the trachea, and the trachea lateral margin, this one. So I set that in, that to the lateral margin of trachea comes the 2R or 4R, right? Not here in the center, but the lateral. For the left side, from the lateral aspect goes to the lateral side of the left side of the mediastinum. So here again in the axial image, you can see here the structure, subclavian artery, left common carotid artery. This is the, which one is the brachiocephalic trunk should be there. This is the left innominate vein, this is the right innominate vein. So this region is the 4R vein. This is the esophagus with the trachea. So now coming to the, this is how we pictorially you can see the level 1 lymph nodes looks like. In the same picture, level 1, again 1R and 1L has been shown in this picture. Is for 1R, that take the name. This is the 1L, the 1L. Again 2R, 4R, etc. It's also very clearly shown. This is the 1L lymph node as shown here. This is the 2R lymph node. And here 2R and 2L again, that I already said. The next is the prevascular node, that is 3A. That means the nodes which are located anterior to the vessels. For the right side, it should be located anterior to superior vena cava. For the left side, it should be located anterior to the left common carotid artery. Left common carotid artery. Yes, there are 3 lymph nodes which are located behind the trachea. But we must remember, as shown in this picture, this is the superior vena cava for the right side. So anterior, there should be the sternum here somewhere. Behind the sternum is the superior vena cava. This is the frenulum. Whichever nodes are lying interior to that, this is called the 3L lymph node for the right side. This is the trachea from the thoracic inlet up to the level of the carina. This also 3 is from the thoracic inlet up to the level of carina only, not other lymph nodes. And this one, which are lying behind the trachea, is the 3P lymph nodes, and 3P lymph nodes for the right side. It doesn't exist for the left side. If 3P lymph nodes are positive for the left side, should be N3 group. For right side comes the N2, for left side comes the N3 group lymph nodes. So this is the same here shown, right? So it's in the pictorial diagram, you can see again where is the 3A and 3P lymph nodes. Yes. So this is again the 3P. this in the same picture. So 4R, 4L, etc. as shown in this picture, 4R, 4L. Now coming to the 5 and 6 lymph. This again in the CT scan, the societal image. You can very clearly see this is the superior lymph column. This is the first rib, so this will be the thoracic inlet. So in the societal image, we identify the superior lymph column. Adjacent to that, where lies the thymus, the nose strip there lies lying here. This will be classified with 3A, just behind the sternum. So this is the sternum, this is the superior vena cava, and this is the 3A group, the lymph nodes of the CT scan. This is also a very clear picture in the axial image. Here is the superior vena cava, whichever is like interior to the superior vena cava. In the right side, it should be classified as 3A. Again, 4R, 4L, I mentioned before, in the CT scan also you can see the similar picture. Imagine just this is the aortic arch, right? So this is the upper margin, and this is the lower margin where the PA starts. So in that way, we can transfer from here to here, this with the 4L, from here to above this, the 2L of the lymph nodes. So, knowing about the CT scan pictures, we can make a very accurate classification of the nodes also. And this also very clear. This is the 4R, and here just here by the side of the left side of the trachea is the 4L lymph node. You can visualize it. So here in this picture also 4R, 4L, 2R, 2L, again 2R, 2L, 4R, 4L. Very important is level 5 and 6 lymph. So we must remember that this is the aortic arch, and this is the ascending aorta. This is the ductus arteriosus. Generally, what happens, whichever lymph nodes are located medial towards the mediastinum, towards the heart of the ligamentum arteriosus, and lies interior and lateral. This interior and lateral to the ascending aorta and the arch of aorta. That should be level 1, level 6 lymph nodes. Whereas this is the main pulmonary artery, left side. This is the aortic arch, which lies in between, that we call the AP window. But this lymph node should be located lateral to the ductal arteries, not the medial one. So if they are located lateral, along the surface of this artery, beneath the aortic arch, that should be called a level 5 lymph node. So here also show this one, the picture. So here, typically in the coronal image, we can see this is the aorta, this is the pulmonary artery. Here lies the level 5, and anterolateral to the arch of aorta lies the level 6 lymph nodes. So get this very clearly. So here, again in this axial view, also we can see along the anterior lateral margin of the aortic arch like the level 6 lymph nodes, right? Again, going down, is the main pulmonary artery left side is arising. So here should be level 6 lymph node, here should be level 5 lymph node. If we talk about the 4L lymph node, here should be the 4L lymph node, right? So now coming to the inferior mediastinum, this is the level 7 to 9 lymph nodes. So very important for us is the subcarinal group of lymph node, that's called the level 7 lymph nodes. So how do we define? We first define the carina. So from carina, in the right side, this is the upper lower locus, this is the truncus intermedius, and truncus intermedius now divides into the middle and lower locus. Up to this level bifurcation from the carina is the right boundary of the subcarinal lymph. Where the left side, which is not equal, you can see here it's longer in this side, it's lesser in this side. In the left side, up to the upper border of the bifurcation in the upper and lower locus. So this should be the left lateral margin of the level 7. So this group of the lymph nodes is the level 7 lymph nodes. Level 7 lymph node is always ipsilateral. And then for the right side is also level 7, M2. To the left side is also ipsilateral, C2. Now coming to the level 8 lymph nodes, so we draw a straight line from the thoracic inlet in between the trachea like this here. Identify the esophagus. So along the esophagus, but beneath the end of the subcarinal group of the lymph nodes, where the level 7 lymph nodes ends, then beneath that only we can take it level 8 along the esophagus. If above that, that will be level 7 because esophagus goes through that area also. So beneath, must remember the first point beneath that, and we draw a midline. Whatever lymph nodes are lying to the right side, we call 8R. Whatever lymph nodes are lying to the left side of the esophagus, we call 8L. These are the paraesophageal lymph nodes. In the same way, we can define the along the inferior pulmonary ligament also. 9L and 9R. So these are the mediastinal lymph node group. Now coming to the higher, this is very important. I will tell why. So quite a lot of time we confuse the level 10 and 2R. For example, the right side, that closely associated. So the 10R lymph node, 11, 12, 13, 14, I mentioned before also. So for 10, we must remember that lies along the main bronchus, first cell. So if you have defined in the surgery right main bronchus or left main bronchus, which are node lying along the right main bronchus, and you lift the lung through the, for example, typically talk about the right side first. So this is the main bronchus. We now deflect the lung towards the mediastinum. Then we will define there will be the truncus intermedius, right, during the surgery. So it goes up to the truncus intermedius when bifurcates to the medulla and lower areas. Now comes how do we make a margin between the subcarinal group of the tenor? मेरो कुरो बुझेछ छैन किन ब्रोकस त्यसरी गाएर त्यसैको एडजस्टमेन्ट त हुन्छ त्यही भएर these higher lymph nodes or level 10 lymph nodes are located along the bronchus, not in the medial sides. For subcarinal group, the subcarinal is essentially to the medial aspect of each bronchus, okay? But whereas along the bronchus it will be the level 10 lymph nodes. For the left side, it goes along the pulmonary artery also. So the bronchus and pulmonary artery goes together. So along the pulmonary artery also, except level 5 lymph nodes. After that, it will be considered quite a lot of time during surgery. We find when the pulmonary artery hugs like this on the left side, there are the lymph nodes that will be classified also as the level 10. So this is the level 10 as shown in this picture. This is the right main bronchus, the level 10, this is the left main bronchus with the level 10. So level 11 I mentioned in the right side is in between the lower bronchi. So in the right side we have the 2, is the upper lobe truncus region is called 11S. Between the midline road is called 11 inferior. Superior inferior. And the left side is called 11. Okay. So now in the nodal stations again this could be N1, N2, N3. This just to remember which group of the lymphocytes we can call N1 and which called the N2 for the left and right side. But it's important to remember these stations again emphasizing this whatever I said. For right side, this boundary makes the 2R dual to the left side of trachea. Again, remember, we must remember these things. So now this again, for example, is the tumor between the hilum. This will be N1 group of the lymph node, as shown here. It goes to the mediastinum. This will be the N2 group. It goes to the second N2 to the left side. It goes to the contralateral. That should be basically as shown in this picture. Here also N3. If it goes to the supraclavian, again this is the N3. If it goes to the axilla, this is not the regional lymph nodes for the lung cancer. So that should be a stage M1 disease. Or if it's going to the intercostal lymph node along the intercostal disease, again is the M1 disease. If it is going to diaphragmatic group, again M1. Or it is going through the internal mammary chain, again the M1 group. Now let's see some of the CT films. So now here, clearly shown, right innominator then left innominator junction here. So whatever lies before the transection above that should be the 2L or 2R, sorry. And beneath that, that will be the 4R, where the transection is the transection, I mean, into the trachea has not been already. Drainage into the especially has not arised, right? So it still is the 2R group of the lymph nodes as depicted in the blink currently. This the trachea, the 2R should be up to the left side of the border of the trachea. 2L will be from that side, another side is the 2L, right? So here also again in the CT scan, coronal image, as I said before, this is the 1R, 1L. This much will be the 2R, this much will be the 4R, this will be the 10L. Yes. Now coming the next picture here, this is the 3A, because it's a prevascular and anterior to the splenic. This is the 3P, because behind the trachea, retrotracheal. This is the 4R, because after insertion of the left innominator going into the spherical cava. This is the 4M, because this rise beneath the aortic arch or lower margin to the pulmonary artery. Pulmonary artery has not been shown here. In the next picture, you can find. This is the level 5. This is the level 6. Is it clear? And substitute picture at the same level, we can define those all the lymph nodes. In the coronal image, again, you can define the same things also. Sagittal image, sorry. We can define the same thing 4L4, but we have to to the 3D because all the way to the NPR view and CT scan, you can find everything also in the sagittal images also. Same picture there, 4R, 4L, 6, 5, 7, and 8, 8, and 9, and 9. So CT scan as a picture on the face. Again here the same picture, 10 and 10L has been shown, but 10R, because it's the right nucleus. So whatever goes along the right is 10R. So the 10L is here, right? With the 11S, interlobar. With the 11I between the middle and lower limb. And this is the 11 simply the left side between the upper and lower, right? So now let's summarize this all stuff. So again, just not to do level 1, level 2R, 2L, 4R, 4L, 6, 5. Same thing having 7, 8, 9, 10, etc. So now very important now comes to us is how to define, sometimes quite confusing. How will you define this lymph node? Is it the mediastinal or is the higher lymph node? We must make a boundary. So it's obviously not just the carina. So whatever may be lying beneath the carina along the right members, we can call it level 10, but it's not still is the carina. So then not by any means this could be the higher lymph. That's the 4R, right? So now this is the huge picture shown by the IASLC. So now among that, we have to define now where is the boundary between the 1R, 1L and the mediastinal, because this group of lymph node is the 2R, this group of is the 1R. So if you misclassify the 2R, if you take it classify as 1R, this will be N3 disease. This makes a huge difference. The N3 disease has never come for the surgical and has never become a surgical candidate, whereas N2 selected patient cannot go surgery. So there is a huge difference in the treatment protocol also. Therefore, it's very it's essential to identify the margin, where is the border between the 1R and 1L and the mediastinal group. Similarly, there could be so. Now let's take an example of the subcanal. How will you define the subcanal group? So this typical the triangle area is here is the subcanal group. Right? How will you differentiate, as I said before, from the 10R or 10L? So that this subcanal group lies along the medial side of the bronchus, right? With the 10R and 10L lies interior or the lateral aspect of the bronchus. So that is a little bit different from the subcanal group. So in that way, you can define with the 10 group of the lymph nodes where the subcanal. So therefore, the question where is the right hilar or the right mediastinal lymph node again comes. How will you define the border between the level 10 and then 4R? Because they are quite adjacent to each other. 4R means above the zygous arch, 10R means below the zygous arch. So there should be a boundary. To a boundary when in a CT scan, very particularly we have to define where is the zygous arch. Then above the zygous arch, inferior border of the zygous arch, we can see that we have to recognize during the CT scan. So you can see here in the CT scan, this is the lower margin of the zygous fin. This is the zygous fin that will drain into the So whatever lies above that, that should be plus 1. 4R, what will be lying below that is will be So here in the CT scan, right highlight is the level 10R as shown in this picture. So in the left side also, we can tell the similar things, similar way of the identification of the level 10. Now, lower cervical versus upper mediastinal, I emphasized in the beginning. We check the first rib as a marker. So whatever lies above that is the level 1 lymph node supraclavian. Whatever lies beneath that will be the mediastinal lymph node. Same thing, but only don't forget to check the left lateral margin border of the trachea, shown in this picture. This one is the subcanal lymph node, right? And here the paraesophageal level 8R, level 8L. There should be the inferior pulmonary ligament lymph node 4R, 9R, and 9A.
Some percentage mediastinal or whatever what college is
subcanal but right side go correct, right? The is the lower margin so correct. Prevascular also 3A is very clearly seen. Here, same way, same thing. There is a nomenclature like calling the precarinal lymph. But in this classification, there is no lymph node called precanal. Precanal should be taken as right or left. It should be either the right 4R or left 4R. and orange brick anatomy. There's a double nomenclature to those lines. The same thing. Here again the same image. Here the same image. Now again revising those things that I said. What are the criteria for defining this the positive lymph? As shown here, 2003 Journal of Test it was published in about 6,000 of patients. 77% of patients that were pathologically anterior had at least one node more than 1 centimeter. 12% of the patients that were PN1 and PN2 had no node more than 1 centimeter. Therefore, 1 centimeter criteria is arbitrary. And it's not always true that it should be 1 centimeter. Again, this is the short axis. This should be the long axis. This is the short axis that we have to define during the CT scan imaging. Right? So FDG PET, if normal FDG PET value is uptake is less than 2.5, whatever lies above that, we can think that this will be either inflammatory region or the malignant region. So this is the huge classification of spread of the lymph node system. So by which virtue you can define? Do you use the big percutaneous FNA or trupet biopsy? Do you use the EPUS or EUS or some VATS medias or VATS procedure or mediastinoscopic procedure? Which lymph node group of the stations you can sample by any particular diagnostic tool? This I have told already. So define the fat density, homogeneous, hypervascular, necrotic, etc. So now this is the 9th edition classification. N0, N1. So whatever from 2009 was published, the staging system till now, 2025, has not been changed in the nodal staging except at one point. N0 remains same. The previous classification in this classification also. N1 remains also same. Only the change has happened in the N2 group, which have classified into N2A and N2B. Before, whatever is the mediastinal lymph nodes are called the N2A. But in this 9th edition, they said if the solitary single station is positive, that we take as N2A. There's the multiple stations here, like subcanal fora, that has to be taken as N2B group. Because this N2A group is still candidate for surgery, whereas the N2B upfront surgery is never recommended. So this makes even the treatment protocol changing. So we must remember that. N3, obviously, whatever, there's no change in the N3 group. So there is only single change happened in the N2, which divided into A and N2B in this recent classification of 9th edition. So that has been here also depicted in this picture, what the changes have been made. So this, I will not repeat this thing again. It's just for summary. What are the stations that we classify? This is again the summary. So now we are the surgeons, and we must remember that the most important point, I think, for us. So how do you define the boundary during the surgery? So you take this picture. The lower limit is the inferior pulmonary ligament. You can visualize the lymph node here. So definitely that should be the along the level 9. Right side 9R, left side 9E. Here again we see the left side. Picture from the left side. This is the descending aorta. This is the inferior pulmonary ligament. This is the phrenic nerve pericard in the lung, right? So again, level 9 lymph nodes are those lymph nodes which are located along the inferior. We have divided the inferior pulmonary ligament. This is where the picture. So level 9 lymph node ligament. So again, this is the level 9. And level 8 on the left side is the esophagus. So whatever lies along the esophagus, the level 8 lymph nodes are shown in this picture. Again, during surgery, we always attempt to define it. It's the left side of the esophagus. The descending aorta is the left vagus, right? These are the vagal branches we divide during the dissection of the lymph nodes, right? So in this again in the left side. So now again this clearly see here. Left side again, aorticus, recurrent latitude nerve. This is the C1, primary canal, the right membrane of the left membrane. So this boundary up to here, this will be the level 7 lymph nodes, right? This is the right membrane, the left membrane. These are the level 7 lymph nodes that we have to identify. But remember, again, I'm emphasizing here, if the nodes will be here, then it will 10 lymph nodes. So this boundary we have to define. Sometimes there's a conglomerate of lymph nodes we can not differentiate, but the higher lymph node is given the priority. If there's both N1 lymph node here and N2 lymph node, then definitely there's the lymph node. So again, the same picture, very clearly seen. The left main bronchus, the right main bronchus, right? यहाँ मेरा bifurcation देखिएगा ऐसे, यहाँ मेरा हाउस है, ये देखिए, ठीक है? Level 7 lymph nodes, triangular form house. So again, the left main, inferior pulmonary vein, right? यहाँ मेरा artery कति होला? अब इसमें so level 10 lymph nodes that I said, level 7 यतातिर थियो होला. Level 10 is the left main bronchus. Along that will be the aneurysm lymph nodes answer. That's the level 10. Right? Again in the same picture, very clearly, left main bronchus, right main bronchus with the subcarinal space. So I'm back to there, sorry. The main bronchus go along the level 10. Now this is the aortic arch shown here. This is the ascending aorta. This is the arch of the aorta. Whichever lymph nodes are lying here, anterolateral, either here up to here, that we classify as level 6 lymph nodes. And whatever lies in the AP window, but the lateral to the ductus arteriosus is called the level 5 lymph nodes, right? 4L is the trachea, your pulmonary truncle, your left side of pulmonary artery, right side of pulmonary artery. You would say arch of aorta, upper margin, lower margin, right? Your trachea, so your ductus arteriosus. So this boundary here, this will be the 4L lymph, so that we can depict during the surgery also. Here also, very recapitulated, look at the left side. You can very clearly see this along the left main bronchus, left PA, which goes inside. So this lymph nodes are level 10 lymph nodes. I know here should be the level 5, here is the level 7. So this makes the boundary where lies the level 7 and where lies the level 10 lymph node. Okay? So this we can depict during the surgery. Here also, question that has a left side there is collection. This is the PA, your lymph node full group of 10 or 5. Right? Your lymph node full group ko hola, 10 or 5 is the visceral pleura. So that was the level 10 lymph node backwards. Right side ko हामी ट्र्याकोटोमी गर्दैछौँ. Diagrammatically represents a trachea. So always 4 is the 2R is the 4R. So for that we should check the margin on the left side of trachea. It goes here now again comes to the midline, right? This person 8 ola 9R 9L or 8R 8L. Then this here. The 4L again is shown in the pipe from the different view. From the different view. Different view. Different view. We have a 4L depict it's also from the different view. Now, prevascular lymph is the 2L prevascular lymph node. It's the left common cavity arch. The swelling on anterior to that or anterior to the superior vena cava. Yeah, sir, this could be undefined as one.
2 years are anterior to superior vena. 3. 3. 2 years should be on the lateral side. Lateral node. Anterior posterior lateral node.
Here go lateral. 2 years. मैले बोल्दाखेरि mistake गरेको थिएँ ठीक छ again here clearly छ 3A 2L भने यहाँ हुन्छ अब common carotid artery को यहाँ interior भएको that would be 3A for the left side, right? This is the carotid artery, this is the subclavian artery, the 3A group of the lymph nodes very clearly seen here 3A. Now for the right side, the left side को मैले follow गरेँ, the right side again inferior pulmonary ligament यो छ. They like cardiac that with the level 9 lymph node. Here is the inferior pulmonary ligament. There should be a diaphragm. You have detachment and is the level 9 lymph node. Yes, level 9 lymph node is gone. This is the esophagus, right? This is the zygous vein. Level 9 lymph nodes will be here and level 8 lymph nodes will be here. So we are taking with the ligas root, the level 9 lymph nodes. So the packet of the subcranial group of the lymph nodes. Can you right main bronchus to left main bronchus? Your truncus intermedius to border goes there. Yes, some of the subcurrent level 7 lymph node. Again, as shown in different picture, different diagrammatic view, level 8 lymph node, but level 8 lymph node only can rest if they had the picture one. It's subcurrent lymph node. Again, this one, level 10 lymph node, is like I said, level 7 lymph node. So, यसरी चाहिँ हामीले लेबल गर्न पर्छ भनेको दुरिङ सर्जरी. Pictures are speaks for themselves, right? typically lateral right side muscle, digestional, phrenic nerve, kinderacone, vessels wala, ke wala, and typically pictures of muscle देखिरहेछ. This we are very fond of defining the triangle in the superior mediastinum to the right side. This is the apex, this is the superior vena cava, should the trachea, should the zygous vein. So now we define arbitrary. And यसरी होला यहाँले left innominate vein each junction होला 2R and 4R. Boundary 3A or 3B.
Sorry, left side मा चाहिँ 2 र 4 को डिफ्युज बीचमा aorta arch of aorta आउँछ नि above that 2 below that 4.
Aortic arch को upper border सम्म upper margin सम्म that 2R from upper margin to the lower margin or pulmonary artery level सम्म that will 4L.
Yes, मा चाहिँ right मा चाहिँ के हुन्छ?
Right मा त यो innominate vein भयो. यसको lower margin सम्म thoracic level 2R हो. त्यहाँदेखि lower margin zygous vein सम्म 4R हो. बुझ्नु?
हजुर.
राइट मा चाहिँ मार्जिन देख्न अलिकति विषय गर्नुपर्छ र हामीले आइदेखि हाफमा डिभाइड जस्तो गर्छ सब्सक्राइब.
Again same picture. The 2R ले तुमले भने जस्तै के 2 र 4R. यहाँनिर छ very clearly seen right side मा छ हामी this superior vena cava is the zygous vein. ठीक छ? यसको लोअर बाउन्ड्री यहाँनिर चाहिँ कताबाट यहाँनिर देखिया छैन पिक्चर यहाँनिर कताबाट चाहिँ left innominate vein यहाँ ड्रेन गर्नुपर्छ. त्यसपछि यो मार्जिन भन्दा माथि thoracic iliac सम्म 2R होला. यसको भन्दा यहाँदेखि तलसम्म जहाँ यो zygous vein को लोअर मार्जिन सम्म 4R.
यहाँ यो 2R यसरी 2R लेखेको छ के हामीले सर्जिकली हेर्दा यसरी जोडिन्छ देखिदैन.
हो यसमा पनि क्लियरली देखिया छ र फेरि है
पछाडी देख्यो.
उले पछाडी यही देखिया छ. यसमा अब झन् क्लियर छ हैन. यसको यतापट्टि देखे भित्र गएको भए यहाँबाट left innominate vein यहाँबाट 2R यहाँसम्म 2R हुन्थ्यो. यसको मुनि 4R थियो. यो left innominate vein यहाँ छ यहाँले जोइन भयो होला नि यहाँदेखि यहाँ
जोइन भएको लोअर मार्जिन सम्म
हैन. अब यहाँबाट 4R गयो यहाँको लोअर मार्जिन सम्म. ठीक छ हैन. So again यहाँबाट हेर्दा this is the superior vena cava, this is the phrenic nerve, and this anterior to the superior vena cava 3A lymph group. ठीक छ. This should be the 4R group, right? Yeah. So 2R. 2R. Thank you very much. Yeah, open slides also. I know where I take questions. I just wanted to make it clear. Okay, questions. Definition. I will define. Jota stage migration will happen if we don't particularly see, visualize, and classify them improperly. Particularly, this improper adjustment happens when classifying the superclad and the 2R or 2L group. To classify 4R and 10R lymph node group, or 4L and 10L lymph node group, and subcarinal level 7 and 10R subcarinal 10L. यसमा चाहिँ जजमेन्ट चाहिन्छ कुनलाई के भन्न त हाई र mediastinal कन्फ्युज भयो भने स्टेज माइग्रेसन छ वा डाउन स्टेज गर्नेछ वा अप स्टेज गर्नेछ त्यही भएर यो पर्टिकुलरली हामीले डिफाइन गर्न जरुरी छ एन्ड आई थिंक व्हाटएभर आई हैव सेड वी कैन डिफाइन बाइ द सीटी स्क्यान इट्स पोसिबल इट्स नट भेरी बिग डिल हामीले प्रपर सीटी स्क्यान इमेज भयो भने सो आई रिकमेन्ड डाक्टर नेहा अल्सो that we read the CT scan properly and try to identify which stages are there. The next time when some patient come with the lung cancer, you can see the visualizer and try to identify. This is this group of it and this is this group of it. The questions are... निकाल्नै पर्छ भने जरुरी छ निकाल्न आवश्यक पर्यो because for the staging for the lymph dissection त्यो निकाल्न नै हेर्नलाई त जरुरी पर्दैन यो टिकासलाई थोरै मोबिलाइज गरे त्यसको मुनि गयो अनि देखिहाल्छ ट्र्याकिया सरी छ लेफ्ट मेन्टल सरी छ पिए सरी छ
त्यो सब सिटी स्क्यानमा हामीले तपाईको लिगामेन्ट एकदम आर्टिसन त देखिदैन अहिले हैन
सिटी स्क्यान डक्टर सर 6 स्लाइस हो यदि ओब्लिटरेटर उसको कति एमएम छ
भन्छ हामीले त एकदम डिफाइन गर्नको लागि
एकदम थिन स्लाइस
4L र 5 को छुट्टाउनको लागि चाहिँ हामीलाई एकदमै राम्रो स्लाइस चाहियो
तर हामीले एज अफ नाउ right उठ्न going to future 4L is again the entry basis level 5 is again the entry this doesn't make much difference I mean misclassified
exactly but फीमा चाहिँ हुन सक्छ सर बट सिटीमा डिमार्केसन गर्नलाई चाहिँ डिफिकल्टी त्यो चाहिँ स्पेसिफिक हुनु पर्यो है सर। अनि अर्को भनेको चाहिँ अब जस्तै 3 को पनि त तपाईँको 3 को एन्टेरियर पोस्टेरियर छ, एन्टेरियरको पनि लेफ्ट राइट र 2 एन्टेरियर छ है सर।
3 को 2 एन्टेरियर
ए र पी छ
क्यानल हैन 3A भनेको
एसबिसी को ठ्याक्कै 12 o'clock-मा
त्यो 3A
3 अब एसबिसी को 3 o'clock-मा
3 o'clock that we cannot visualize from the right side. त्यसलाई mediastinal pleural cover to the left side बाट मात्रै, but from the left side you will not see the SBC unless you twist the pleura, unless behind the sternum you go to visualize it.
जस्तै अब लेफ्टमा ट्युमर भयो, लेफ्टमा ट्युमर भएर तपाईँको हामीले एसबिसीले भिजुअलाइज गरिदिने लेफ्ट साइडबाट गरिदिने। लेफ्टमा ट्युमर भइसकेपछि इन्ट्राअपरेटिभली एसबिसी को माथि ट्युमर छ 3A ट्युमर नोड छ भनेपछि त्यो N1 डिजिज हो, N2 डिजिज होइन।
N3 हो नि
3AR भयो भने
3AR भयो भने N3
अपोजिटमा गयो नि त, लेफ्टको तपाईँको राइटमा जानु पाएन N3 भन्नु पर्यो।
लेफ्टको त 3A भन्ने बित्तिकै सोच्नै पर्यो त N3 डिजिज भनिहाल्नु
हैन। 3A भन्नलाई लेफ्ट साइडको 3A भनेको उसको N2 डिजिज along the left common carotid artery सबक्लाभिन आर्टरी देखिन्छ नि, त्यसलाई पिक गर्यो भने त्यसलाई चाहिँ N2 डिजिज नै भयो। त्यो भन्दा बियोन्ड उता गयो भने त्यो द्याट विल नट भिजुअलाइज फ्रम द लेफ्ट साइड, सुपर भेनाकाले देख्दैन नि।
पर्टिकुलर इफ द नोड इज पोजिटिभ अन नोड ढालेदेखि एसबिसी को अगाडि पछाडि भनेपछि तपाईँको लेफ्ट साइडमा छ भनेदेखि त्यसलाई त उसिन कन्सिडर फर एन्ट्री भन्नु पर्ने छ। लेफ्ट लोबको ट्युमर छ, एसबिसी को ट्युमर देख्यो,
त्यो भए त N3
एन्ट्री भयो।
त्यो त सर्जरीमा
हाइलाइट नै चाहिँ त्यहाँ छ भने कन्ट्रोल
सर्जरीमा जाँदै गयो
गयो के सोधेर मैले बिर्सेँ त्यो 4 इयरको लागि
अनि 3A भनेको सरी एसबिसी को मात्रै होइन,
3A भनेको एसबिसी मात्रै
क्यारोटिडको पनि हो।
राइट साइड
त्यो दुईटा भेसलको अगाडि हुनु पर्यो।
राइट साइडको लागि एसबिसी,
लेफ्ट साइड
कमन क्यारोटिड लेफ्टको कमन क्यारोटिड त्यो हो यो लेफ्टले
एकदम इम्पोर्टेन्ट डिफरेन्स भयो।
तिमीले जुन भनेको छ नि जस्तो यो ट्र्याकिया राइट मेन भन्नुपर्छ म लेफ्ट मेन भन्नुपर्छ ठिक छ। यहाँ the aortic arch is like this one. Our doctors are able to see it. So PA is coming from here. But it's saying in the don't ever tell him. It's not. Our here doctor are just committed is out. Aortic arch to put in. PA saying yes. PA but PA is the middle. It's not about aortic is this station. Behind the motion, behind the so check. So that is the fourth for our aortic. त्यसरी चाहिँ भने यो हरेक लिम्फ नोड हामीले निकाल्न र 4 इयर लिम्फ नोड डाइसेक्सन लेफ्ट साइडको चाहिँ मान्छेहरूले एलसीसीएममा के लेखाएको छ कि व्हाट इज द mediastinal lymph node systemic sampling or mediastinal lymph node for left side you have to take out the 4 ear lymph, but I have seldom seen the European surgeons or even the American surgeons taking out the 4 ear. 4 ear त सबैले लिन्छ, 2 ear पनि लिन्छ, 4 ear लिँदैन, it is quite cumbersome. त्यहाँ जाऊ रिकरेन्ट ल्यारिजेनल पनि त्यतिकै आएछ, इन्जुरी हुने चान्स धेरै हुन्छ भनेर डर लाग्छ हैन। लेख्न त लेखाएको छ गाइडलाइनमा, हामी पनि सधैँ गर्दैनौँ 4 ear किन पोजिटिभिटी रेट इज अल्सो लेस र निकाल्न पनि गाह्रो। अरू के छ भन्नु
निकाल्दैन, निकालेपछि यसरी के
हुन सक्छ फ्युचरमा आवश्यक 9th एडिसनमा ल्यायो उसले N2 लाई डिभाइड गर्यो हैन, N2 हामीले सोलिड अर्गनहरुमा स्टमक कोलोन रेक्टम सबैमा नम्बरिङ गर्ने यति नम्बर रेस्ट
डक्टरले पनि भन्छ सर नम्बरिङ गर्छ
यही हो। तर उनीहरु नम्बर भन्नाले यति लिम्फ नोड निकाल्नु पर्ने, अब स्टमकको N1 भयो 2 to 7 N2 भयो मोर देन तर यिनीहरुले नम्बर भनेको छैन के, नम्बर वाइज के न फिगर
स्टेसन वाइज म्याप वाइज गरेको के
हो उ जस्तो
पेरिकोली मात्र निकालेर 20 वटा 25 वटा पेरिकोली निकालेर सेटल नोडै निकालेन भने त कहाँ गयो
त्यो भन्नु खोजेँ त्यो त मैले भन्न खोजेको जस्तो कि त्यो त एउटा पार्ट हो, त्यो त सर्जनको उ भयो के एरर भयो। G2 ग्यास्ट्रेक्टोमी भनेको छ 15 वटा लिम्फ नोड निकाल्नु परेको छ, G1 ग्रुपको लिम्फ नोड निकाले पनि भइहाल्यो नि, 15 वटा त पुगिहाल्यो, त्यो चाहिँ न डिफ्रेस हो नि, सबै लिम्फ नोड स्टेसनले निकाल्नु पर्यो। तर नम्बर भयो स्टेसन त भयो नि, नम्बर भन्नाले काउन्ट गर्ने के 2 टा 5 टा 10 वटा 15 वटा 20 वटा, तर लङ्समा त्यो नम्बर भएको छैन। भनेर 5 वटाले N1 भन्ने हो कि 10 वटाले N1 भन्ने त्यो भनेको छैन कि उसले स्टेसनलाई मात्रै फोकस गरेको छ अरु केही छ भन्नुस् कसैको केही क्वेशन आशिष तपाईको आउटगोइङ सेभरल यसमा आउन सक्छ so my first question to you would be what group of the lymph nodes you can sample by mediastinal cervical classical mediastinal
2L, 2R, 4L, 4R, 7.
7 and can we take out the level 10?
10 also we can.
Yes. If you want to do by the mediastinoscopy, take out the level 5 and 6 lymph. Is it possible by the classical mediastinoscopy?
It's not possible by classical method. We have to do extended cervical.
Extended cervical mediastinoscopy. So, so before the invention of the extended cervical mediastinoscopy, there was another procedures to take out the 5 and 6. Chamberlain procedure. Now, let's take another view. We have defined the classical view, extended cervical mediastinoscopy, and there is a concept of tumula or gamla. Do you see any advantage? Complete mediastinal dissection using the mediastinoscopy.
So if you do the complete mediastinal system, there are a few advantages. One, you can do the complete mediastinal staging, so which will help us to decide whether to undergo further surgery or not. Number one. Number two, in the intraoperative period, we need not undergo the systematic mediastinal sampling according to the limit.
The main advantage there are the proponents which comes from the Poland particularly, Poland and Sweden. So Poland but in medical as well. So if we do this sort of mediastinal lymphadenectomy, so definitely they formally exclude any NT disease. Because if any NT disease, then they prefer for vernier surgery. But still, during the surgery, you have to take out the lymph. So if you do the formal cervical mediastinoscopy, to take out all those lymph nodes. During the main surgery, you don't need to take out all those lymph nodes. And the complete mediastinal lymphadenectomy has been done up to the group 7. Indeed, level 8 and 9 have not been dissected. That may not be necessary. There was a advantage more. The main disadvantage given the learning curve is high. It has not been popularized, not very popular all over the world. When a selected group of surgeons are doing this, incisions are quite bigger, and you need to do some technique to lift up the strap. Those are subjugated approach thymoectomy गर्छौं त्यसको एउटा डिभाइसले लिफ्ट गर्नुपर्छ ताकि भिजुअल त्यत्रो स्पेसबाट जाने छ so quite cumbersome त्यसै गर्न now are there some options level 8 and 9 you cannot take out by Chamberlain procedure, you cannot take out by the EVAS. If there's some way to take out the level 8 and 9
can sample the level 8 and 9 lymph nodes by using the endoscopic ultrasound.
And if not, that fits. We don't have. Or so there are certain indications for diagnostic VATS. Also, initially it has been written in the textbook. Before the nodal staging, VATS is one of the modalities to stage it properly. So what you think? If you what's the importance of this classification? Let's suppose CT showed you, even the PET scan showed you, okay, there are negative mediastinal lymph. I learned normal. You took the patient for surgery. Now you found that there's multiple stations. You took the frozen section biopsy, it comes to be positive. Mediastinal multiple stations. What will be approach?
Ideally, if multiple stations are positive, then it has been found that surgery does not improve the overall survival of the patients. So ideally, I would abandon the lobectomy and proceed for neoadjuvant.
So you should add to that. This very correct answer is what it is. If somebody has done the open thoracic, then that they would love to finish it. Because according to this the American trial, I don't remember this, was something trial that showed that even those contexts you do the surgery, complete mediastinal lymph node dissection and get with the chemo radiation after operation. That is the survival advantage. But provided the complete lymphadenectomy has to be done, no residual disease inside. And that was the previous practice also. But if you have done with the VATS, small incision, if found is positive, then you cannot run in the first place. Therefore, the VATS is always better. होइन त्यो कारणले चाहिँ राख्छ अरू केही क्वेसनहरु anything else mice we are going to chat about earlier these things may happen there I don't know what's their practice assisले हेरेर चाहिँ सबै कुरोहरु चाहिँ बुझेको राम्रो so nodal staging is very important for the lung cancer not only for the non-small the small cell lung cancer there is another chapter big chapter how to stage it properly but at best recognize the lymphodepletion surgery they aid गर्छ सागर मनोज सचिन
एउटा क्वेशन चाहिँ मेरो नाममा ल्याइया त्यो लेभल 7 छ नि त्यसको हामीले लोअर लिमिट लोअर बर्डर अफ द ब्रोंकोसिटेटिस र त्यो भन्दा तल नोड छ भने चाहिँ 8 and 9
भनि हाल्यो नि 8 इसोफेगस प्रोब्लम 8 and 9
अनि along the bronchus
along the bronchus
के भइहाल्यो त्यो त
त्यहाँ ब्रोंकसै हुँदैन पहिलो कुरो त्यसको मुनि त ब्रोंकसै हुँदैन ल्याटरल साइडमा हुन्छ ब्रोंकस that will level 10 in level 10 up to the bifurcation in the right side up to the bifurcation in the left side beneath त्यो भित्र छिरोको ब्रोंकसमा आयो भने त इन्ट्रा लेभल 11 12 13 14 के होला हैन त तलतिर केरानीको उयो त ब्रोंकसै हुन्छ त्यसरी हामीले
डिसेक्ट गर्न त्यो
त्यो इन्ट्रा
ब्रोंकस बनाउँछ नि त सर सन्तेन नोडहरु सर्जिकल
हो त नि त्यो त बार्टिनसम्म जस्तो कि
एघारको मेन ब्रोंकस 11 हुन्छ
जस्तो कि एक्जाम्पल हैन यो चाहिँ राइट ब्रोंकस हो सर राइट ह्यान्ड ब्रोंकस कोही खुट्टाले कुद्दै यहाँ हामी त्यसरी रिफ्लेक्ट राइट साइडमा छ पेशेन्टको लङ्सलाई त रिफ्लेक्ट गरेछ लेभल 7 त यहाँ आउँछ हैन यो यहाँ छ यो चाहिँ मिनको टेम्पो यहाँसम्म हुन्छ ठीक छ लेभल 7 अब तपाईले कुरो गर्दै चाहिँ यो लिम्फ
मैले त्यो भन्दा तलको भनेको
यो भन्दा तल ट्रङ्कस इन्टरमिडिएट
पोस्टेरियरली नै नसक्छ
पोस्टेरियरमा यसरी रिफ्लेक्ट गर्दाखेरि ब्रोंकसको ल्याटरल मार्जिन anterior margins are up to the bifurcation into the middle and lower lobe and street level 10 to the desk of भित्र गयो भने चाहिँ लेभल 39 त्यसको पनि यता त ब्रोंकसै हुँदैन त तलतिर त अब लेभल 8 9 के होला
त्यो लेभल 10 मलाई हामीले पुरालाई रिफ्लेक्ट गरेर मात्र हुन्छ भएको छ त्यो भन्दा बाहेक अरू सबैको 7 नै भयो त्यो त्यसमा देख्दैन गरेर प्रब्लम भयो जबसम्म हामीले त्यो डिसाइड गर्दा पुरालाई त्यो रिफ्लेक्ट नगरिकन त 10 देखिने नै होला
by definition त हो any hilar lymph node that has been closed inside the viscous and त्यसको enclosed envelope बनाएर त्यसको भित्र हुन्छ एउटा झिल्ली त हुन्छ त्यसलाई हामी फस्काउँदै गयो भने आउँछ र त्यो झिल्ली नदेखिन पनि सक्छ त विश्व कुरा अलिक गर्न आएपछि खासै गर्दैन त्यसो है त्यो खासै त्यो अर्थ रहँदैन तर हो त्यो सही कुरो खालि त्यो मैले त्यो क्लासले यसरी डिपिक्ट गरे के मेडियस लेभल 7 ग्रुप अफ लिम्फोस भनेको यो मेडियल साइडमा हुन्छ यसको यहाँनिर हुने एन्टेरो वा ल्याटरल साइड अफ द ब्रोंकस लेभल 10 यसरी बुझ्यो कि बुझेन त्यो गोलो भयो नि त ब्रोंकस त गोलोको यता मेडियल साइडमा गयो भने लेभल 7 जस्तो कि एक्जाम्पलले लङ्समा गाह्रो हुन्छ भने इसोफेगस सम्झ कि इसोफेगसमा तिमीले सोझै सबकारण लिम्फ देखिन्छ नि किनभने मेम्ब्रेनस पोर्सन देखिन्छ त्यहाँ ठ्याक्क सबकारण लिम्फ हुन्छ किन उताको पार्ट त मेरो एन्टेरियर ल्याटर त देख्दै देख्दैन त्यसमा है त्यहाँ जाँदै जाँदैन है सोझै सबकारण त्यसरी डिपिक्ट गर्न लङ्समा चाहिँ तिमीलाई गाह्रो हुन्छ त्यो भने कुनै सर्जरी गर्दाखेरि चाहिँ हेर्नु अरू केही